This is Dr. Amy Tai, and she's going to talk about atrial fibrillation. So she got her Bachelor of Arts in Biology and Economics at Johns Hopkins University, Doctor of Medicine from University of Maryland, internship in medicine at Mercy Medical Center in Baltimore, Maryland, her residency in neurology at the University of Southern California, and she did her fellowship in vascular neurology at Stanford University, and she's currently one of our vascular neurologists here at Christiana Care Health System. So welcome, Amy Tai.
Hi, good morning, guys. I know I'm the last talk before lunch, so please don't mind me. Hopefully I don't hear a lot of rumbling stomachs, but that's okay. Mine might be rumbling too. Okay. So today I'm going to be talking a little bit about subclinical atrial fibrillation and its risk for stroke. I don't have any off-label medication use disclosures. The only financial disclosure relevant to this talk is that I'm an endpoint adjudication committee member for one of the trials I'll mention very briefly at the end. So the objectives of the talk today will be to review a cryptogenic stroke evaluation. I'll dive into a little bit about the breakdown of how we categorize stroke mechanism after somebody presents with an ischemic stroke, and then discuss what the utilization for prolonged cardiac monitoring is for this patient population, and then what's the next step after we discover that they may have subclinical or paroxysmal AFib. Now, I know there's a very diverse audience, and I want to make sure I'm kind of addressing everybody. So as a kind of just show of hands, like how many people diagnose stroke or treat stroke in an acute setting? Okay, some of you guys. And then how many of you guys take care of stroke in like a rehab setting or, okay, and then other healthcare professionals and nursing that take care of patients in acute stroke or in the stroke rehab facilities? Okay. And then what are the rest of you guys? Just want to come in for free lunch? Or okay. Okay, all right. So I'll try to make my talk a little bit relevant for both the diagnostics for the clinicians that will be evaluating clinically for these patients, as well as for the other paraprofessionals, what kind of things that you may encounter in the acute hospital or the rehab settings when you may see patients with some of these monitors, et cetera. So briefly, as many of you guys may already know, atrial fib usually has no symptoms. The obvious ones, I think, are for the patients that show up in the emergency room or clinic complaining that they're short of breath or lightheaded or they feel their heart is bounding out of their chest. But a lot of times and frequently when they present with an end organ thromboembolic event, it's because their AFib has gone undiagnosed. The definition of paroxysmal AFib, kind of arbitrarily set by the cardiology community, is self-limited intermittent AFib events lasting 30 seconds or longer. And this is the diagnosis or the clinical definition that is used for the prolonged cardiac devices that we're going to be talking about later. So the reason why it's important to talk about AFib is it can actually change our medical therapy for secondary prevention stroke, what happens after a patient presents with a stroke, or even if they present with subclinical or silent AFib, say they just got diagnosed on a random EKG, how managing them and risk stratifying them for preventing future thromboembolic events is important. So this is kind of how we break down in the stroke literature, how we break down stroke diagnoses. Here I listed what's, I would say, most stroke. Does this have a laser? Oh, here. Most stroke physicians would break down stroke mechanism, either small vessel, large vessel, cardioembolic, or cryptogenic, and then the modified TOES criteria also includes 2 or more or other. Typically, and this is in the acute setting, what you guys would be seeing for our ischemic stroke patients, they would be getting some kind of parenchymal imaging, usually MRI, maybe head CT if you're in a resource-limited constrained area, routine blood work, vascular imaging of some kind. So at least carotid vessel imaging, and obviously this kind of breakdown and treatment explains why, or intracranial imaging as well, so MR angio or CT angio head and neck, and structural cardiac imaging is frequently encountered. The reason why this is important is that you can see here that the mechanism of the mechanism of stroke kind of helps guides what kind of therapy the patients will be getting. Certainly, if they have large vessel disease where cervical carotid is the cause of their disease, these patients are the ones that we're referring to surgery. Medical management is more commonly seen for intracranial large vessel disease. That's what intracranial atherosis falls under. Small vessel disease. And cryptogenic currently, our current knowledge is that we would be using kind of the same treatments as intracranial athero or small vessel, but cardioembolic certainly the gold standard of treatment would be anticoagulation. And it's the difference between these two categories, cryptogenic and cardioembolic, where I'll be spending the bulk of my talk later today. The main difference, as you can see here, is aside from risk factor modification, is antiplatelet versus anticoagulation. One of my, I don't think I'm the only one, and maybe other stroke physicians here can speak to that, is how to differentiate between antiplatelet and anticoagulation. I would say most people kind of lump aspirin and Plavix with anticoagulation, but really that's all antithrombotic therapy, and antiplatelets focus primarily on aspirin with clopidogrel or Agrinox, and anticoagulation would be what we traditionally think of warfarin, high-dose Lovenox, or some of the novel oral anticoagulants that we'll be talking about. So they're really different, and the mechanisms they work under are different, and we would risk stratify patients depending on their stroke mechanism to different therapies. So here is some idea of what we would be doing for people who present with cryptogenic stroke. The definition of cryptogenic stroke essentially means you do the routine workup, so head imaging, vascular imaging, plus minus structural heart imaging, and some type of cardiac rhythm monitoring that traditionally has been at least a screening EKG when they're in the emergency room, or frequently what's used is impatient telemetry 24 to 48 hours. And then I would say classically that is kind of, oh, that's the complete stroke workup. And then out of that group of, say, 100 patients that come in, about 30% of them end up getting diagnosed with cryptogenic stroke. It just means, I don't know why this happened. Your EKG was okay, your blood work was okay, your carotid ultrasound was okay, and let's just hope it doesn't happen again. Now, of course, I kind of enumerated the, I would say, common stroke workup, but certainly I have seen patients where they may show up in clinic and for whatever reason they had an incomplete evaluation during their initial presentation, or another group of patients where they had a missed stroke, such as I had one patient recently whose wife brought him in actually for confusion or mental status change to clinic, and it turned out that he actually had a right temporal stroke 2 months ago and has had short-term memory loss since then, but nobody knew that he was actually had a stroke was causing his memory loss. They thought it was like early signs of dementia or something. And then certainly there may be other multiple causes or a truly unknown cryptogenic state. And these are usually categorized by either embolic appearance or non-embolic appearance on imaging. And I think this is why an MRI is particularly helpful for these patients where there's no clear diagnosis or cause to explain their stroke, because there are certain kind of imaging characteristics that would help us suggest that this is more likely to have come from a proximal thromboembolic cause versus a more typical small vessel or hypercoagulable cause. So the embolic causes are sort of broken down here into either cardiac structural abnormalities, rhythm abnormalities, arch athero, or a hypercoagulable state associated with cancer. I think non-embolic causes, I know Dr. Wozniak certainly mentioned genetic associated strokes, as well as other primary thromboembolic or hypercoagulable states, although they may present as an embolic appearing stroke as well. Less common stroke etiologies, here's a long laundry list. I would say that it's okay that you don't necessarily know what the cause is, but these are kind of like things to think about and, you know, may tickle or jog your memory. You're like, oh yeah, I think I've heard about that. Like, and these are kind of the common clinical features that you may take into history taking that should kind of like trigger your memory a little bit. So if any time somebody's reported recent trauma, and the trauma can either be accidental, like whiplash, or intentional. Frequently, it's after people choose to go to get a neck massage or chiropractic, and then they have associated face or neck pain. Certainly if they have a Horner syndrome where their eyelid's a little bit droopy and their pupil smaller on that side, or other kind of peripheral nerve symptoms, you may think that it's an arterial dissection. Other less common causes, we talked about hypocoagulable states, so either acquired or genetic hypocoagulable states like antiphospholipid syndrome with genetic thrombophilic diseases, occult cancers. This is actually, I think, one of the few, I shouldn't say few, but one of the times that the review systems is really pertinent to my job is when I'm asking about constitutional or B-type symptoms like night sweats, weight loss. Oh, you smoked 60 pack years? Oh, really? Okay. So those kinds of things are helpful when you're thinking about other less common stroke etiologies. Rarely, and I get called about this frequently when the echo orders here still include a right to left shunt diagnostic test. So I would say this is rarely seen. Usually it's associated with one of the genetic syndromes like HHT, or if they've had prior surgical or some other kind of lung problems before, but this is rarely the cause. And they usually have atypical clinical features that will kind of help elucidate that. So the structural cardiac evaluation, I think typically most people think, oh, it's standard workup to get a transthoracic echo or a transesophageal echo. And I think there are different schools of thought about this. Some of it is that it's not really clear that it's cost effective to be doing this for everybody. My personal opinion, although this is not necessarily represented in what's our standard care pathway here at our hospital or in many places, would be to first evaluate for large vessel disease. For example, if you already know that the patient has their carotid is 90% on one side and that's the side of their stroke, why would it matter what their echo looks like? Unless, of course, the surgeon who's going to be operating on the carotid thinks that they want to know what their cardiac risk factors are. But generally, it's not going to be really changing management. So I would propose to do a stepwise algorithmic plan where you would evaluate for large vessel athero, because that's really about 20-25% of your strokes. And then the yield for a structural cardiac evaluation is relatively low. It probably only changes management 3 to 5% of the time. So that I would probably do that later. Next, a pretty common and, well, definitely is kind of recommended, although with a very basically no evidence. The current guidelines are to do at least 24 hours of inpatient telemetry. Again, there's really not good evidence for this if you look at the literature, and the cost effectiveness is really questionable. And since now we have more opportunities for prolonged cardiac monitoring as an outpatient, one might argue that we should actually be moving away from inpatient telemetry and kind of moving forward to a place where, unless they have other cardiac indications for hemodynamic instability, that you could go directly to outpatient cardiac monitoring instead of inpatient tele. At my old hospital, we actually looked into this from a cost effectiveness perspective, and we routinely decided to not put our stroke admissions on tele unless they had another cardiac indication, because the yield, unlike some of these studies that suggest that the yield is 4 to 8% of AFib, it was actually under 2%. So, and then one kind of begs the questions like, maybe we can do a better job doing a subset kind of group of patients, say if they're like older and higher risk for AFib or have cardiac structural abnormalities that were predisposed to AFib, that those people may have a higher yield for inpatient telemetry. And as you know, people that work in hospital, you know how inpatient telemetry is challenging from a nursing perspective, the additional kind of resources needed, different nursing ratios, and getting them off tele for tests, et cetera. So there's probably benefits all the way around. So here is kind of where the kind of meat of the talk focuses on. I listed the different types of outpatient monitors available, as well as I'll go into a little bit about what they each look like. So if you guys encountered them in your practice, you may have seen patients with physical therapy and wearing one of these. You'll know what they're about and how to kind of manage them. So traditionally, Holter monitors have been around forever. They are continuously recording, usually for up to 48 hours. Event monitors have been around for quite a while as well, and they're primarily only working when patients have symptoms and they're triggered by either an abnormal rhythm and they start recording, or the patient feels a symptom and they kind of press a button and it starts recording. A continuous loop recorder will continue to record data, and then it's kind of like a tape recorder that can erase and then record new information, and it can both be triggered manually as well as record before and after the event. And the latest, newest kid on the block is the implanted loop recorder that is programmed to be triggered by an arrhythmia or by a patient manually electing it, but it's actually implanted subcutaneously under the skin of the chest, and the recording can actually go up to 3 years without a battery change. So I'll kind of show you guys pictures so you know what these look like. Here's a Holter monitor. You can imagine how I would say patient compliance is variable with this device. It's only 48 hours of recording, and I'll go into a little bit about why maybe that's not quite long enough for what we're using it for, detection of subclinical AFib for cryptogenic stroke patients. And another major burden is that the cardiologist at the hospital who has to review the entire set of data, 48 hours of recording. So, and you can see how it's a traditional fully leaded on the chest, and it's kind of cumbersome for patients. A newer version of different cardiac monitoring devices, one is called the IOxp patch. I'm a little biased because it was invented at Stanford, so I know the founders, but we've been using it for quite a while, and I think it's slowly made its way over to the East Coast. And now, if you talk to the device reps, they have about 40% coverage for insurers here. It's a 2-week duration. It's not in real time, so which means that it's recording just like a tape recorder, but you're not going to get any phone calls in the middle of the night if the patient goes into supraventricular tachycardia or anything, because what the patient has to do is that they take off the patch, put it in a box, mail it to the company, and then later, after the fact, we would get the information that they're having SVT or AFib or et cetera. So I would say from a patient compliance perspective, this is well received because, as you can see, it's pretty minimally invasive. I describe it as like the size of a tegaderm or something, the size of your palm. And then the little part that juts out a little bit more is really the size of like a matchbox. And that is where the recording device is. And it's really easy to use. So the reps do recommend that a trained professional do it, but it could really be anybody from an MA or higher level could do it. However, I have had plenty of patients who just want to take the box home and read instructions and put it on, and there's a 1-800 number in the back and they can kind of use it. And since it's basically a big Band-Aid, I feel like it's pretty easy to do. I think the Holter, as you can see, where lead placement is so onerous, that this probably should be put on by somebody that's like an EKG tech or higher. The CardioNet, I think, I'm kind of going in order of duration of monitoring. So the Holter is 48 hours. The Zio patch goes up to 2 weeks. And the CardioNet is a little bit longer. It goes up to 30 days. This is kind of like I would say, a better version of the Holter. You can see it's 3 leads. It's attached with this like little Palm Pilot type device. And this is real-time transmission of information. So some people might argue that that's a good thing, where, for example, the patient does go into a prolonged run of SVT. You're the neurologist on call. You could potentially get woken up at 3 a.m. about this, and then you have to decide, should I call the patient, make sure that he's still alive, tell him to go to ER, what do you do? Or it may be a con if you don't want to get woken up saying the patient's in SVT. So this kind of automatically gets sent up via the cloud to the monitoring center, and you still get a report that will be triggered by their algorithm where there are runs of abnormal recording. And it's usually, at least the arrangements in the facilities I've worked in, it's usually arranged with cardiology where the cardiologist will still overread the algorithm, which means kind of like the telemetry in the hospital. If there's something that gets triggered as abnormal, a cardiologist or human would be looking at that strip and making sure, oh yeah, this wasn't just lead placement where the patient was sweaty and the lead fell off, that this was an actual arrhythmia. Oh, the Zio patch is the same thing. It's overread by cardiologists, used usually at the ordering facility. So the way we have it here, is that the CardioNet is actually always ordered by cardiology. What it means is that our patients who we think need some type of prolonged cardiac monitoring, we refer them to cardiology just to get this device. They don't necessarily need a full cardiology consult, but fortunately for us, cardiology group has been willing to take over the ownership of those kind of infrequent but middle of the night calls where the patient may have some kind of potentially lethal arrhythmia. And so the neurologist is not kind of like scratching their head, like, what does that mean? 3 seconds of heart block. Should I do something about it? I'm not sure.